Before beginning the procedure, open the lumbar puncture kit on a bedside table. Sterile gloves must be worn when handling the contents of the package. Open the collection tubes and place them in the holders in the LP tray. Note that the tubes are numbered, and it is essential to fill them in the correct order to assure proper analysis of results. Assemble the manometer, which will be used to measure the opening pressure. First attach the three-way stopcock to the bottom glass tube and adjust the lever so that the device is open to the patient and the manometer column. Next, attach the top glass tube to the bottom to complete the assembly. The choice of spinal needle used has a direct effect on the incidence of post-dural puncture headache. Standard spinal needles, often referred to as Quincke needles, have a bevel tip much like an intravenous catheter. The edges of the bevel function as a cutting surface and leave a relatively large rent in the dura after lumbar puncture. Persistent leakage of cerebrospinal fluid through this rent may lead to post-dural puncture headache. A variety of atraumatic spinal needles are commercially available, which may reduce the incidence of post-dural puncture headache. Pictured here are the Whitaker and Sprott needles. These devices feature a relatively blunt tip and a side port for CSF drainage. The tip of the atraumatic spinal needle does not cut the dural fibers during penetration and thus leaves a smaller rent which limits the amount of CSF leakage. The use of atraumatic spinal needles is highly recommended to reduce the incidence of post-dural puncture headaches. If only standard spinal needles are available, use a 22 gauge rather than a 20 gauge needle to reduce the size of the rent left in the dura. If using a standard spinal needle, pay careful attention to the orientation of the bevel during insertion. If the needle is inserted in a bevel up position, the bevel edges tend to cut through the dural fibers, which run in a vertical fashion. If the needle is inserted with the bevel facing laterally, which is the appropriate technique, the edges separate rather than cut the dural fibers. Note that prepackaged lumbar puncture trays usually contain standard spinal needles, and atraumatic needles will need to be added to the field separately. All spinal needles, regardless of design, contain a stylet that must be fully inserted into the needle whenever it is advanced or withdrawn. In adults, the spinal cord terminates at the level of the L1 vertebrae, and thus entry into the spinal canal must occur distal to this location. The fibers of the cauda equina extend distally from L1, however, they float freely in the CSF and are not likely to be injured by the advancing spinal needle. The L3-L4 or the L4-L5 interspace is the preferred location for lumbar puncture. Note that the L4 spinous process is at the level of the iliac crests, making these interspaces relatively easily identified. The spinous processes extend from the vertebral bodies in a caudal fashion. If the spinal needle is inserted perpendicular to the back, it will contact the superior surface of the spinous process below the selected interspace. Proper technique mandates that the needle be inserted in a cephalad direction, which will allow for entry into the spinal canal. During insertion, it is helpful to aim the needle toward the umbilicus or higher to facilitate proper needle trajectory. In the neutral anatomic position, the spinous processes are relatively close to each other, which may make lumbar puncture difficult. Instructing the patient to flex the back as much as possible will result in splaying of the spinous processes, which will facilitate entry into the spinal canal. Position the patient lying on her side in the fetal position, with the back flexed and at the edge of the bed. The spine should be parallel to the floor, and the plane of the back should be perpendicular to the bed. Careful attention to meticulous body positioning is essential in lumbar puncture. Incorrect positioning may cause the needle to contact the spinous processes or travel out of the anatomic midline, leading to failed dural puncture. Palpate the iliac crest, which is at the level of the L4 spinous process. Next, identify this spinous process as well as the interspaces directly above and below. Either the L3-L4 or the L4-L5 interspace may be chosen. Mark the entry site with a skin marking pen. Switch to sterile gloves and begin to prepare the area with chlorhexidine or povidone iodine. Use gradually increasing concentric circles to apply the antiseptic. Next, apply a sterile fenestrated drape over the region. Position the top of the drape over the patient's hip so that the iliac crest may be repalpated during the procedure if necessary. Place an additional sterile drape on the bed that can be used to hold equipment. Using a 25-gauge needle, place a wheel of local anesthetic in the epidermis overlying the selected interspace. It may be beneficial to palpate the spinous process during this step, but great caution must be exercised to avoid injuring yourself with the needle. Next, direct the 25-gauge needle through the wheel and inject an additional 1 to 2 milliliters of anesthetic. During anesthetic administration, direct the needle in a cephalad direction to facilitate proper passage through the spinous processes. Switch to a longer 22 or 25-gauge needle and begin to anesthetize the deeper tissues. Intermittently, pull back on the plunger during injection to exclude inadvertent vascular placement. Again, be sure to direct the needle in a cephalad direction. In general, between 3 and 5 milliliters of anesthetic are used. If you are using an atraumatic spinal needle, first pierce the skin with an 18 to 20 gauge beveled needle. This step facilitates entry of the relatively blunt-tipped needle through the epidermis. When inserting and advancing the spinal needle, rest your non-dominant hand against the patient's back and steady the needle with the thumb and index finger of this hand. This technique prevents inadvertent, uncontrolled displacement of the needle should the patient suddenly move. If using a standard spinal needle, remember to orient the bevel laterally toward the patient's side. The stylet must always be fully inserted during entry and advancement. The stylet prevents the lumen of the needle from becoming clogged with debris, as well as the deposition of epithelial tissue into the spinal canal, which may result in an epidermoid tumor. Begin to advance the needle toward the spinal canal in the anatomic midline, directed in a cephalad fashion aimed at the umbilicus. As you advance through the tissues, stop every 5 or 10 millimeters and withdraw the stylet to check for fluid return. If you meet bony resistance during advancement, the needle is likely contacting the spinous process inferior to the interspace and will need to be repositioned. First, withdraw the needle so that only the tip remains under the epidermis, and then redirect it in a more cephalad direction. Again, advance the needle, checking for fluid return as you proceed. It may be necessary to partially withdraw and re-advance the needle several times during the procedure. Note that additional local anesthesia may be required if the patient experiences discomfort as the spinal needle is directed in different trajectories. If you are still unable to enter the dural space, remove the needle and prepare to make another attempt. Reassess the patient's positioning, making sure that the back is maximally flexed and that the spine is parallel to the floor. Repalpate the landmarks and confirm the exact location of the anatomic midline. In this example, a repeat attempt was made at the next higher interspace using the same sequence of steps as before. Again, place a wheel of local anesthetic in the epidermis overlying the entry site and anesthetize the deeper tissues with a longer needle. If using an atraumatic needle, first pierce the skin with a beveled needle to facilitate skin penetration. Gently advance the spinal needle into the interspace in a cephalad direction, aimed toward the umbilicus. You may feel a slight, yet distinct popping sensation when the needle pierces the dura. Remove the stylet to check for fluid return. CSF will flow from the needle hub once the subarachnoid space has been entered. Next, attach the manometer to the hub and measure the opening pressure. Allow the glass column to fill and obtain the final reading. Normal pressures are less than 20 centimeters of water. Remove the manometer and begin to fill the specimen tubes. Recall that the tubes are numbered and must be filled sequentially for proper data analysis. A total of 4 tubes are filled, each with approximately 1 milliliter of spinal fluid. Additional fluid may be obtained if special studies, such as extended microbiological cultures and stains, are clinically indicated. Once the last tube has filled, reinsert the stylet and remove the needle. Finally, remove the drape, wash the back to remove the residual skin cleansing agent, and place a bandage over the puncture site. Remember to dispose of all needles in an appropriate container. Lumbar puncture may alternatively be performed with the patient in the sitting position, using an analogous technique as described earlier in this video. The sitting position may be preferable in patients who have respiratory distress, are obese, or have obscured landmarks in the lateral recumbent position. Opening pressure may not be assessed in sitting patients, and the added risk of a fall if the patient has a vasovagal episode during the procedure makes this position less desirable. Position the patient sitting at the edge of the bed with the arms resting on a pillow on a bedside table. Encourage the patient to curl forward so that the back is flexed as much as possible. It is essential to have an assistant monitor the patient throughout the entire procedure when using this precarious positioning. Palpate the iliac crests and identify the L4 spinous process, and choose either the interspace above or below. The remaining steps of the procedure follow the same sequence and techniques as described in the previous section. The skin is cleansed and a sterile drape is placed. A wheel of local anesthetic is deposited over the selected interspace, and then the deeper tissues are anesthetized. A small puncture is made with a beveled needle, and then an atraumatic spinal needle is advanced in a cephalad direction aimed toward the umbilicus. The stylet is removed, and the cerebrospinal fluid is collected. Finally, the stylet is replaced, the needle is removed from the back, and the skin is cleansed and a bandage is placed.